Bone disease is a really big issue in cancer. Well, it is in breast cancer and it is in prostate cancer. As we know, we have huge randomized trials in both those disease processes. Particularly in breast cancer, you can give oral bisphosphonates in the adjuvant setting and actually improve survival. There are two key aspects. They're lytic bone metastasis and sclerotic. Lytic associated predominantly with breast cancer, but also it's the lytic lesions very much driven by this osteoclastic activity that we see in renal cancer as well. And you can see here, this is Andrea Rockel, who's our radiologist, who's put together many of these slides for me, and I have to thank her for that. This is a classic X-ray of what she calls bubble lesions, these huge areas that have been punched out of this individual's pelvis, and we're going to see more of her X-rays later on. It's destructive, it's progressive, not necessarily multifocal. We know in prostate cancer we see these sclerotic multifocal lesions, whereas in renal cancer we often have patients with one or only two sites of disease. The key to this is the initial focus on the trabecular bone, and this is where the disease starts. And actually, these early lesions are best identified by MRI, and I'm going to show you some of those images later on. Bone metastases are common, occurring in 35% of patients with metastatic disease, but importantly, they're associated with an increased risk of MSKCC, poor risk disease, and also a poor outcome. So this is the same data. This is the survival of patients who were treated with bone metastasis and those with no bone metastasis. And you can see this group are doing significantly worse. I'm going to come back to the process because the process is important. And the key to this is as the metastatic process starts, one of the initial focuses, particularly this work is from breast cancer, is into the trabecular bone. And you can look very early, both in prostate and breast cancer, but particularly breast cancer, and identify early metastasis in the trabecular bone. And clearly from there, the disease progresses and then goes into the cortex, causing destruction. This is a highly cellular metastasis, so the characteristics of this disease is a very highly cellular process, and this is a diffusion MRI scan, and basically what this means is it looks at the restrictive movement of water, so water naturally moves via Brownian motion, and if you have a very cellular pattern, this should shine up very brightly. This is your normal MRI scan on the left here, and you can see this is the most sensitive way we have at the moment of identification of early disease. You can see there's nothing here. This is a diffusion MR, we use these in prostate cancer, and you can see this hot spot here, and this turns out in the future to become a progressive lytic lesion, and this is a very early identification of bone metastasis. What I'm going to do very quickly is just go through that process of this early development and maybe describe some of the implications which it has in renal cancer. And I'm sure we all have seen this picture before. This is a cartoon, but the key to it is the tumor cells are stimulating osteoblasts, which in turn are stimulating osteoclasts, and it's the osteoclasts themselves that are causing a lot of this damage, a lot of these lytic lesions. And osteoclasts are somewhat unusual in that they're made up from basically hemopoietic lineages, and so they're a fusion of monocytes and premature macrophages, and they're often described as hemopoietic progenitor cells. And so there really is a link between the bone marrow and the bone function. And it's more complex than that because there is a complex interplay between the tumor cells themselves and the osteoclasts. And there's this positive feedback loop where we get stimulation of osteoblasts, we get the hemopoietic progenitor cells forming osteoclasts, we get osteoclast activity, bone destruction, and subsequent to that, overexpression of a series of crucial growth factors, the most important of which in breast cancer is thought to be IGF-1, which in turn stimulates the tumor cells. And it's this progressive pathway, this progressive destructive pathway that we saw in that original X-ray of the person with renal cancer. And indeed, if you look in detail at these hematopoietic progenitor cells, you can see they are overexpressed in the serum of patients with renal cancer, and indeed this overexpression is associated with a poor prognosis in metastatic disease. And one of the interesting things is when you give Sunitinib, you can decrease their expression, and then if you stop Sunitinib, it results in a rebound. And what this is suggesting to us is that these targeted therapies are having a direct effect on the bone marrow, which indeed may have an effect on the progression of bone marrow metastasis. And this is a correlation between IGF-1, that important growth factor that I talked about, and the hematopoietic cells. And this is suggesting that this drive that I've talked about could potentially be turned off with Sunitinib, breaking this loop and reducing this destructive cycle. On the left here is a CT scan, and you can see this large destructive lesion. And this is actually the same, this is a later X-ray from that same person with the earlier destructive lesion I showed. And you can see how it's eaten away at the bone here with very few bone remnants remaining. And this is an FDG PET scan. And what this is showing us is not a dormant lesion, but actually a metabolically active lesion, indeed with even a necrotic center in the middle, demonstrating how powerful this is as a driver of the disease process. And indeed, when you start Sunitinib on this patient, there's no change in the size of the lesion, because we know that bone lesions are difficult to change in size. But if you look at the SUV uptake, the decrease in PET activity, there's a decrease. If you look at hematopoietic progenitor cells, there's a reduction. And you look at IGF-1, there's a reduction as well in this specific patient. And what this is suggesting to us is that not only are bone metastases common, but they're very active. And they're also associated with a poor prognosis. The dynamic interaction in this feedback loop may be driven by protagonists of the hematopoietic progenitor cell system, particularly macrophages. IGF-1 appears to be important. Targeted therapy may be able to temporarily block this loop, and novel techniques can be employed, such as diffusion MRI, to identify very early lesions, but other techniques, such as fluoride PET, may also be useful. So the take-home message from today is that bone metastases are relatively easy to identify with more novel techniques than simple bone scanning, but it's more than just a simple structure like the Eiffel Tower. It takes part in the city, and it has a role to play in the progression of disease. I've got a couple of minutes left, and what I thought I would do is just talk very briefly about osteonecrosis of the jaw, because there is a lot of talk about it in the literature at the moment, and I'm just going to go on to this. This was a quote from Oncology, the last paragraph in their summary. The combination of bisphosphonates and anti-angiogenic agents induce osteonecrosis of the jaw more frequently than bisphosphates alone. A very provocative statement, and one that concerns me. The pathogenesis of osteonecrosis of the jaw, it's driven again by macrophages. It's the inhibition of these macrophages, which in turn results in inhibition of osteoclast activity. And this is a reduction in the tumor bone turnover, but also it's characterized by an infective process. And I just want to go through the evidence very quickly in the last minute. So this is the review article in The Oncologist, a retrospective analysis of 116 patients given targeted therapy alone or targeted therapy with bisphosphonates. Bisphosphonates alone or bisphosphonates plus targeted therapy. And 16% versus 1%. This was only 5 cases driving this data. And in my opinion, it was somewhat inadequate, because we go over to this breast cancer retrospective analysis of over 3,500 patients, and the incidence 0.9 to 2.4% for the combination, compared to 1 to 6% for bisphosphonates alone. So the way I summarize this is that yes, this is provocative data, but the comprehensive data from breast cancer suggests to us that currently giving targeted therapy and bisphosphonates together is safe. Many thanks for your attention.